Now we will start the anticholinergic or parasympathetic drugs. Actually, this drug blocks the action of parasympathetic nervous system. In previous videos, we have discussed what happens when the parasympathetic nervous system is stimulated and what happens when this is blocked. Now we will discuss these anticholinergic drugs according to organ on which they work. At first, we will recall the mnemonic from our previous videos. The mnemonic was, in our daily life, our first priority is eating. And when our stomach is full, we can then hear to heart. Then all other things in our life will come. M1 receptor is situated on stomach, and here eating means stomach and fast resembles M1 receptor. Then our second work is here to heart, and second here resembles M2 receptor and hearing to heart resembles M2 receptor are located on heart, and then all other things comes third. So M3 receptor are located at all other organ, bronchus, gastrointestinal tract, smooth muscle cell, urinary bladder, glands, etc. We have discussed about those earlier. At first, we are going to discuss about M1 receptor. We previously said that M1 receptor is situated in the stomach. So, this is our parietal cell of stomach, and our parietal cell contains a pump which is known as proton pump, which expels hydrogen from cell and potassium enters. This hydrogen in stomach binds with chloride ion and forms hydrochloric acid. The parietal cell contains M3 receptor, and when this M3 receptor is stimulated, this causes stimulation of parietal cell and the hydrochloric acid is released. So blocking of M3 receptor will lead to decrease in secretion of hydrochloric acid. But here is a catch. Actually, when food is in the stomach, the brain sends signals to the stomach by vagus nerve, and that causes release of acetylcholine in the ganglion of enteric nervous system. And this ganglion of enteric nervous system contains M1 receptor. This acetylcholine is released and stimulates this M1 receptor. This causes release of acetylcholine from ganglions of enteric nervous system, and this acetylcholine binds to this M3 receptor. Thus, this M3 is stimulated, and this stimulation leads to increase in hydrochloric acid. So, if we block this M1 receptor, this whole pathway is blocked. As a result, the hydrochloric acid secretion is reduced. So, by blocking this M1 receptor, we can produce a reduction in hydrochloric acid secretion. In peptic ulcer disease, there is excessive hydrochloric acid secretion. So if we block this M1 receptor, there is less hydrochloric acid secretion, and that will help in peptic ulcer disease. So two M1 receptor blocker we use in peptic ulcer disease. Those are pyrenzapine and telenzapine. In our previous video of OPC poisoning, we have discussed a little about atropine, that atropine blocks M1, M2 and M3, means all the muscarinic receptor. So as it blocks M1 and M3, can it be used in peptic ulcer disease? Actually, atropine is contraindicated in peptic ulcer disease, so it cannot be used in peptic ulcer disease. Now I will describe why. In our first slide, we said that our gastrointestinal tract smooth muscle contains M3 receptor. So these receptors are M3 receptor. Remember, parietal cell contains M3 receptor and enteric nervous system ganglion contains M1 receptor. As a result, the food contained in the stomach with hydrochloric acid cannot pass further. So this remains in the stomach for a long period of time and it will cause irritation to the gastric mucosal cell. So the gastric mucosa is damaged, which will aggravate the symptoms of peptic ulcer disease. So for this reason, atropine is not used in peptic ulcer disease, rather it is contraindicated. Then we will discuss about our M2 receptor. From our mnemonic, we know that M2 receptors are located on heart and stimulation of M2 receptor on heart causes bradycardia. So if we block M2 receptor, that will lead to tachycardia. So we can use this utility in bradycardia and AV block. In AV block, actually the conduction speed is reduced by action of vagal parasympathetic nerve on heart. So if we block the vagal action by blocking M2 receptor on heart, there will be no parasympathetic action and only sympathetic action will lead to increase in contraction and that will reverse our AV block. But here atropine has a catch. We know that our presynaptic nerve fiber contains M2 receptor and postsynaptic nerve fiber on heart also contains M2 receptor. Acetylcholine is synthesized, stored and released from the presynaptic nerve fiber. After release, it binds to postsynaptic M2 receptor and some binds to presynaptic M2 receptor. When it binds to presynaptic M2 receptor, that causes feedback inhibition in release of acetylcholine. Means this receptor acts as a brake. But when this acetylcholine acts on postsynaptic M2 receptor, that leads to stimulation of acetylcholine receptor, which leads to stimulation of parasympathetic nervous system. So the final outcome, if we stimulate M2 receptor, there will be no feedback inhibition and acetylcholine release will be more. That will stimulate the postsynaptic acetylcholine receptor and thus stimulation of parasympathetic nervous system. And if we block this postsynaptic receptor, there is no stimulation of parasympathetic nervous system, thus only sympathetic nervous system is activated. And on heart, parasympathetic nervous system causes bradycardia and sympathetic nervous system causes tachycardia. We know that atropine is a M2 receptor blocker also. So if we give atropine, what will happen? Either it will cause tachycardia or it will cause bradycardia. Yes, it will cause both depending on its concentration. If we give it in a low dose, it will only block the presynaptic M2 receptor. So when the presynaptic M2 receptor is blocked, it will lead to more acetylcholine release and that will lead to stimulation of parasympathetic nervous system, which causes bradycardia initially. But when we give the drug in a moderate to high concentration, as the time passes, the drug also blocks the postsynaptic M2 receptor, which blocks the parasympathetic nervous system. So only sympathetic nervous system act and that leads to tachycardia. So if we give low dose atropine, we can see the bradycardia initially, and if we use moderate to high dose atropine, that will lead to tachycardia. Actually, atropine is the drug of choice in bradycardia and AV block. Now, after finishing M1 and M2 receptor, we will discuss about M3 receptor. We know that from our previous videos, M3 receptors are located on bronchus, bladder, eye, glands, etc. And stimulation of M3 receptor on those organs leads to stimulation of those organs. So when bronchus is stimulated, that leads to bronchoconstriction. So if we block the M3 receptor on bronchus, that will lead to bronchodilation. In which condition we will use those drug? We know this drug causes dilation. So we will use this drug on those condition where the bronchus is constricted, and there are two conditions when the bronchus gets constricted. Those are asthma and COPD. So in asthma and COPD, to dilate the bronchus, we use ipratropium and tiotropium. Here ipratropium blocks all the muscarinic receptor, means M1, M2 and M3 receptor, whereas tiotropium blocks selectively M1 and M3. Also, ipratropium is fast acting and tiotropium is long acting. As it is fast acting, it can be used in acute attack of asthma, and as tiotropium is long acting, it can be used for maintenance therapy of asthma. So we know that atropine is a M1, M2 and M3 receptor blocker like ipratropium. Can we use it to treat asthma? The answer is no. There is two main reasons. The first reason is no inhalational formulation of atropine is available. Second reason is it reduces the mucociliary clearance. We prefer those drugs which can be given by inhalational route in asthma to avoid systemic side effect. This is the first reason why atropine cannot be used. Here we can remember that ipratropium contains atropine in its name, so it will block M1, M2 and M3 receptor like atropine. We know that our bladder contains M3 receptor, and stimulation of this M3 receptor leads to constriction of urinary bladder. If we block this M3 receptor, that will lead to dilation of the bladder. So as the bladder is not contracted by using M3 blocker, there will be urinary retention. So all M3 receptor blocker has a side effect that will cause urinary retention. So it is avoided in benign prostatic hyperplasia. In benign prostatic hyperplasia, the prostate is enlarged and the micturition is already reduced. So if we also reduce the micturition by giving M3 receptor blocker, it will cause danger to the patient. So we avoid M3 receptor blocker in patients with benign prostatic hyperplasia. So the urinary retaining condition can be used in overactive bladder or tetracer instability or urinary incontinence. The drugs used for this purpose can be remembered as soft bladder. Here S resembles solifenacin, O resembles oxybutylin, F resembles flavoxate, T resembles tolteridone, and here DAR resembles darifenacin. All these are M3 receptor blocker, and we know that our glands contains M3 receptor. So if we block this M3 receptor, that will lead to reduce in secretion in mouth. That will cause dry mouth. So this drug can cause dry mouth as a side effect. Interesting thing here to remember that the solifenacin and darifenacin are two drugs which especially act on bladder M3 receptor, means they are Vesicoselective. Here vesico means urinary bladder. So these two drugs mainly acts on M3 receptor or urinary bladder. So these two drugs cannot cross dry mouth. We know that our glands contains M3 receptor, and stimulation of M3 receptor on glands leads to watery secretion. So if we block the M3 receptor, there will be less secretion from the glands, and that will leads to dryness. If it reduces the secretion of eye, that will lead to dryness of eye. If it reduces the secretion of salivary gland, that will lead to dry mouth. If it reduces the secretion of sweat gland, that will cause dry skin. It can cause atropine fever in children. In children, the main heat regulatory mechanism is sweating. So, if we block sweating by giving atropine, there will be less heat loss, and this heat gets accumulated in the children's body, and that will cause fever of the children, and which is known as atropine fever. And the body temperature here will be more than 104 degree Fahrenheit. If this fever is not controlled, it will lead to hyperthermia, and this hyperthermia will cause death of the children. This is why atropine is contraindicated in children. This utility of reduction in synthesis can be used in pre-anesthetic medication. We know that our respiratory tract contains cilia, and the mucus is secreted from bronchial cell. So when dust enters through the respiratory tract, it gets trapped in the mucus, and this cilia will expel this mucus and dust secretion. But when a patient is under anesthesia, these cilia are paralyzed. So there will be mucus secretion, and the dust particle is trapped in the mucus secretion but cannot be expelled out due to paralysis of cilia. So this blocks the airway and no oxygen entry in the lungs. As a result, the patient dies due to hypoxia. So if we can block the mucus secretion, there no dust particle is trapped and the airway is not blocked. So before giving anesthesia, we must give an anti-secretory drug. So drugs used as pre-anesthetic medication are atropine and glycopyrrolate. These both drugs are M3 receptor blocker in the bronchus. The next use of anti-receptor blocker are in eye. Stimulation of parasympathetic nervous system in eye leads to miosis. So if we block M3 receptor on eye, that will cause mydriasis of eye. And this utility is used in fundoscopy and refraction test. How? Normally, when we examine the retina by fundoscope, the light enters through the pupil, and we can examine this portion of the retina, means central portion of the retina, and the peripheral portion are not seen in the fundoscope. So as a result, if any abnormality or problem present there, we cannot diagnose. So if we give an anticholinergic drug as mydriatic, that will lead to dilation of this pupil. So now more light can enter the retina and we can visualize a large portion of the retina. That's why in fundoscopy we use anticholinergic drug. But from our previous video, we know that meiosis helps in angle closure glaucoma. So the opposite of meiosis means mydriasis will deteriorate the condition of angle closure glaucoma. That's why it is contraindicated in angle closure glaucoma. Here another thing. This is our ciliary muscle. When an object is here, light passes through the pupil and it has to make its reflection properly on the retina. So by changing the tone of ciliary muscle, we can change the shape of the lens, and by changing the shape of this lens, we can make the reflection here centrally. And this ciliary muscle contains M3 receptor. We know that our ciliary muscle is supplied by number 3 means oculomotor nerve, which is a parasympathetic outflow. From our previous video, we know that 3, 7, 9, 10 are parasympathetic nerve fiber. So if we block this M3 receptor, the ciliary muscle tone is lost and the actual shape of lens is preserved. So we can use it in refraction error test. So anticholinergic drugs are also used in refraction test. But as the lens cannot change its shape accordingly, so if an object is here or here, it will produce its reflection in front or behind the retina. So the actual object is not seen clearly and this is seen as blurred object. So blurring of vision is another side effect of the anticholinergic drugs in eye. So we can use it. So we can use anticholinergic drug in fundoscopy, and the adverse effect is angle closure glaucoma there, and we can use for refraction test, and the adverse effect there is blurred vision. The drugs used for this purpose is atropine, homoatropine, cyclopentolate and tropicamide. Here atropine is very strong cycloplegic drug and the duration of action of atropine is 6 to 7 days, and action of tropicamide is 15 to 60 minutes. So the adverse effect blurred vision will remain for 6 to 7 days in atropine using, and in tropicamide using the adverse effect blurred vision will remain for 1 hour. Normally we will use tropicamide for this purpose in adults, but in children we need to use atropine because in children the ciliary muscle tone is very high. So if we want to paralyze this ciliary muscle, we need to give a strong cycloplegic drug, and that is atropine. But as our age increases, the ciliary muscle tone is reduced. So in older people or in adult, we should not use atropine. For this longer side effect, we will use tropicamide in adults. Now the last effect of anticholinergic drug, and those are on CNS. The anticholinergic drugs used in CNS is hyoscine, which is also known as scopolamine. Remember that both of these are same drug. This is British name and this is USA approved names. I am sure that you have heard about a term motion sickness. In motion sickness, what happens when we travel on a speedy vehicle? Our body moves with it, and the endolymph inside this cochlea pushes the cochlear wall, and the signal goes and stimulates the vestibular nuclei, and Here the neurotransmitter is acetylcholine and vestibular nuclei contains M1 receptor. Stimulation of these vestibular nuclei leads to stimulation of chemoreceptor trigger zone on brain. And we know that when chemoreceptor trigger zone is stimulated, that will lead to vomiting. If we can block this M1 receptor, we can block the total pathway and there will be no vomiting. So hyoscine is a M1 blocker which can be used in motion sickness for reducing vomiting. The another use of anticholinergic drugs is Parkinson's disease. Normally, our brain has a precise balance of dopamine and acetylcholine in our brain. We know that degeneration of dopaminergic neuron leads to Parkinson's disease. So, when these dopaminergic neurons are reduced, the acetylcholine concentration in the CNS is increased. As a result, there is Parkinson's disease. So what we can do here, we can do a reduction in this acetylcholine in the brain, and that will again create a balance between acetylcholine and dopamine. So here we can use muscarinic receptor blocker or anti-muscarinic or anticholinergic drugs. And anticholinergic drugs used for this purpose is benztropine, benzohexol and piperidine. So this is all about anticholinergic drugs. Thank you everyone for being with me.